Welcome to On the Beat, the pulse of gynecologic oncology, brought to you by the Regroupement des Gynécologues Oncologues du Québec, RGOQ. Before we begin, a brief disclaimer. This podcast is supported by an unrestricted educational grant from AstraZeneca. The content, expert selection, and topics discussed are fully independent, and the opinions expressed are those of our experts, free from any influence by AstraZeneca. This discussion is intended solely for healthcare professionals and is for informational purposes only. It is not medical advice and should not be taken out of context. By listening, you agree that this content is not intended for patients or the general public. For personalized medical advice, please consult a qualified healthcare provider. Now let's get started and explore the pulse of gynecologic oncology.
So the hot topic right now is obviously folate receptor alpha, and we know mirvetuximab is FDA approved in the US for platinum resistant, and we're really working hard and very excited and hoping that our patients can have access to it in Canada soon. So that's going to lead to the next question of doing folate receptor alpha on everybody. So can you just explain to members of the RGOQ what does folate receptor testing consist of?
Yeah, so this is a relatively recent test that's very much offered in the US, right? We're lucky that we have a lot of experience on the south of the border to sort of see how it is done, how it's validated. But essentially, folate receptor is mostly looking at the membrane of those tumor cells and see if they express that marker, which is then leveraged using certain therapies, right? It is an immunohistochemical test, and which means it is sort of an antibody-based test that's looking for a certain protein, in this case, FOLR1. And when that protein is detected in the tissue, we perform sort of a chemical reaction that will highlight or change its color, and then that's how we can use a slide and a microscope to sort of assess the regions that have folate, in that case, folate receptor expression.
And is there enough from a biopsy, or do you really need is it omental tissue? Is it other tissue from the surgery? What is the best specimen?
Yeah, there still actually the jury is a bit out on that, even when we're looking at the data in the US. Currently, as far as the best tissue, there's nothing defined. And maybe unlike other tests that we talked earlier, as far as now, at least indication that we go by is usually on platinum resistant, which is more commonly later on, right, in the patient's journey that they may encounter that status. So at that point, we need to know the folate receptor. So we do have a bit of a lead time as such that using the biopsy tissue or the resection tissue, if there is, I think should not really affect care. Mm-hmm. Now, which one is better? Then there are arguments as for, typically the general rule, the biopsy tend to be better fixed, right? So usually as soon as the biopsy is taken, it's transferred into formalin, and then the process of fixation occurs right away, which helps in general with biomarker testing. Resection, the quality or, the fixation of larger resection can be a bit more heterogeneous, depending, on how it is processed, the ischemic time, the pre-ischemic time, and as well as the time it's in formalin, depending on the protocols the lab use. So it usually isn't an issue. I think a lot of these protocols are very much standardized across Canada. That said, it is certainly something to keep in mind. Now, the bigger question actually for folate receptor is the amount of tumor tissue available. Mm-hmm. Given the way it's scored, or we have to give a percentage of tumor cells that are positive. So sometimes it is difficult to give that assessment on, let's say, a tissue biopsy that is very tumor tissue poor. So in that case, I think the resections typically would give a better, representation of the status of the tumor. The other thing that's discussed very much is, let's say, what do you do if let's say you tested on the biopsy and then the result is negative, should you retest on the resection, right?
So that's what I was going to ask. And so right now, from our clinical perspective, it's really based on clinical trials right now. So basically we send it, it gets analyzed, we get a percentage back, and then based on that, we determine whether the patient is eligible for a trial or not. And we have 3 different trials. And so we've had a situation where in one case, like it was like 70%, and then we retested and it was 90%. And so it's kind of like a bit of a gray zone, ambiguous zone. And so like in the era of precision medicine, how do you think like this is perceived, and how do you think we can correct that?
Right. I think most of the tests that we send out in Quebec go actually straight to Ventana. So Ventana is the company that does this particular immunohistochemical test. And, many tumors have this heterogeneous profile. Like you said, I'm, not surprised that you can find this kind of discrepancy. We were asking them, actually, what do you do if you have a borderline positive? It's tricky because if you look at the trial, what they did in their trial, they didn't retest, right? So, they went by, if it was a borderline positive, it was just, called essentially negative, right? A borderline negative, it was still called negative if it was under 75%. So that's sort of the only data we have. We'll have to wait a little bit, as data comes and emerges. In a way, to me, it's very reminiscent to sort of what we see in PDL1, which is also a test that shows a lot of heterogeneity. But yeah, unfortunately, I don't have really an answer to this approach. But certainly, I think, they admitted that in cases where, during their trial, in cases where they, by mistake, tested two sample, because it occurred maybe like the patient had the sample in a certain city and another one, and then they're both requested to be reviewed. And if one was negative and one was positive, they went with the positive one, right?
Yeah, no, of course, because we really want to, based on the trial results, we really want to get patients access to this medication. And, one thing that I do see is right now I'm having trouble convincing platinum-resistant patients to get on one of the trials where, like, it's very rare we have a trial where we can say 100% of the patients will get the medication, and it's actually FDA approved. Right. So if you go to New York or somewhere just south of the border, well, like that's the standard of care. Like you wouldn't even be given the option, like this is what you're getting, and it's going to improve your survival, it's going to improve your symptoms. And they're just kind of like, they're hesitant. Right. They feel like they're guinea pigs, and it's very hard to convince them. At the same time, they're down the road, multiple like platinum resistant. At that point, they're pretty symptomatic. So I think that, once we get it approved, I think it's going to be a huge thing for Canada and in Quebec. And then doing the folate receptor testing, I think we're going to be seeing that much more frequently. And as you said, like, hopefully, ideally, we'd be able to get this on the biopsy. Right. And so what do you see as the challenges of getting it on the biopsy? Is it?
No, I think, we're currently at the MUHC, we're validating the folate receptor. We hope to have it, soon enough. But at this point, I don't see challenges on doing it on the biopsy. Actually, would be easier than many sequencing testing. If we're talking about HRD testing or BRCA testing, we typically want to have a lot of tumor cells. But one of the advantage of actually immunohistochemical tests like HER2, like folate receptor, is that even a relatively small amount of tumor tissue can be interpreted pretty easily. So I think, the bigger barrier to access to biopsy tissue or to an access to in a rapid timeline is going to be about letting a lot of laboratory access this test and validate this test and sort of have as many labs be able to offer it. Question now is, should this test should it be centralized to the major gynae oncology center, or should it be in every community center that has radiology that would biopsy. So I don't know what
and actually it sounds like a bit of a similar story to the HRD, right? So then we have like one assay with one cutoff, but then multiple centers, lots of European centers have also been developing their assay, and I think that's like, you know, another challenge. And you know, HRD testing is coming, and it seems like Quebec is, you know, pretty ahead in the process compared to other provinces. So do you have any insights to the new HRD testing?
Yeah, for sure. In fact, you know, it made me think, I wanted to ask you, as far as when the clinical trial for PARP inhibitor started, did you find some similarity with what you're encountering now with folate receptor with your patient? Or
I think that's actually interesting, but I have to say I was probably a resident or a fellow, so I wasn't enrolling patients, but I'm sure my colleagues and you know, it's really humbling to see how the field has changed, because like that's, you know, when I prescribed Pembro and Lenvatinib, like my colleagues and your colleagues, they were doing the clinical trials, right? And so it's really nice to see how the whole field has developed and is really like moving forward. So I think like mirvetuximab in like 3-4 years, like we'll be teaching the medical students about that, right? And it'll be like a bit of a no-brainer. So it's really interesting and quite humbling. But of course, like, you know, people were on the SOLO-1 and the PRIMA trials. And so I can anticipate that it was probably a similar process.
Yeah, that's interesting. I mean, you know, I can imagine, you know, a lot of these tests, you know, that you have to present to a patient. And I mean, even for us, it's already so complicated to organize the logistics around the testing. I can see how it sort of can look, you know, like a mountain.
So I think like there's a bit of a theme coming along. So like for me, when I get a pathology report for endometrial cancer, I'd want to know like everything from the biopsy right away. And it sounds like ideally, like in ovarian cancer as well, right? We would like to know this BRCA status and the HRD status, but it does take like quite a long time. And like, what do you think the turnaround time for like HRD testing would be?
Just like in the endometrium, there's really this interface, or, you know, this interaction between allowing, you know, access to therapies and clinical decision, as well as, you know, managing resources to allow us to do this in the best way possible. So of course, you know, the answer is always we'd like to have everything, and we'd like to provide everything at the same time. And it was very challenging in the past. I think now it's becoming easier in a way, and that's partly because of the nature of the testing we do. So we used to, and still have in many instances, very fragmented tests that we have to accomplish to essentially complete the profile of an endometrial cancer and an ovarian cancer. By that I mean we will have to do a set of immunohistochemistry, and then we'll have to do a panel, a sequencing panel for a certain gene, and then maybe we'll need a second sequencing panel for another gene, so that we have, you know, we have the complete status. Luckily, you know, we're sort of moving away from smaller panel, and the technology now, sequencing technology has advanced the point where it's much more affordable to have sort of the larger targeted panel, and those are sort of your typical like 500, you know, around 500 gene, like from Illumina, the TSO 500, or the you know, MSK Impact, or the Foundation one, you know, sort of similar technologies. I think that's sort of our way out, you know, and being able to provide as much in sort of the first report and have a full profile. And that sure is, you know, the case for HRD testing. Like for a little while now, we've kind of, I think, been pretty good at testing for BRCA. And then we had this fragmented, again, testing where we were doing thanks to a collaboration with the industry, we would do the My Choice Myriad testing to have the Myriad result on top of that. And that sort of, in a way, was redundant or fragmented, and it certainly wasn't ideal. But currently, I think, with the new tests, at least what we're validating at the MUHC, and also I know other centers are looking into that assay is either the TSO 500 or some of this, other similar tests.
So essentially, like Quebec is developing their own test, correct?
That's true. So essentially, the panels, like the one I've been referencing, is this TSO 500 because that's the one we're currently validating at the Glen. But this is actually an Illumina. It's a company essentially sequencing kit that includes over 500 genes, and so it is actually like kind of it's a pre-made sequencing kit. That said, to put this online, it's not sort of ready to go as you get it. So there's a lot of validation steps, and there are also a lot of things that can be essentially modified. The larger panels give us a lot more flexibility to ask additional questions that are not necessarily just the mutation status for the gene. And by that, I mean, like, for example, like a good example of that might be like tumor mutational burden. So it's the amount of mutation a tumor has per amount of base pair. So tumors that have high mutational burden are often associated with mismatch repair deficiency or microsatellite instability. So it can be like a safety net in some cases where maybe the immunohistochemistry is difficult to interpret or the sequencing is unsure. So just to say that, with those larger tests, and then the other one is HRD. So HRD is not a gene. HRD is essentially a combination, of multiple biomarker that can be accomplished by looking at the results from one of those larger panels. In fact, Myriad had one of the company that offers one of the popular HRD testing has a kit that's that's paired with the TSO 500. So they have a collaboration, and as such that when we do this test, we have the possibility of combining or adding this plus value that is the HRD testing without really doing another test and without really having additional cost for the test. So, that's what we're looking for in the future. And, to answer your question regarding where we're at in Quebec, are we ahead? Well, for HRD testing, I like to think we are, but we... And that's sort of a project that's very close to my heart. I'm at the Glen. We're really actively validating the HRD testing as part of the TSO, and then hopefully we can roll this out and offer that for patients in Quebec. Probably the way I see it roll out is that as soon as we have validated and able to provide the test, then of course patients from in Quebec can be the test can be done on tissue referred from outside. But more importantly is that all the our sort of validation blueprints is easily shared to the other centers, right? So then that's how we sort of help snowball the molecular testing at the CHUM, in Sherbrooke, in Quebec City, so that as many centers can offer this. And
that's great. So it seems like we're really moving ahead and ahead of the game for once, and Quebec is winning at something.
Thank you for joining us on the Beat the Pulse of Gynecologic Oncology. We hope today's episode offered valuable insights. For more content and to stay informed, visit us at rgoq.ca. Until next time, stay informed, stay connected, and continue advancing the care of women with gynecologic cancers.